It is 9:46, so I think we can start the session, The Magic of SICS. This is a popular session that has been going on for last almost 8 years now. And I would request our chairperson, Dr. Jagannath Boramani, to start with his first talk, Milestones in the Journey of ISM SICS. Over to you, Dr. Boramani, sir.
Good morning, all of you. I am the chairperson of International Society of Manual Small Incision Cataract Surgeons. This session, Magic of SICS 1, as well as tomorrow morning, Magic of SICS 2, these two sessions are being conducted by International Society of Manual Small Incision Cataract Surgeons, that is ISM SICS. Now, my talk is not necessarily academic, it is about activity of our organization. So, I request the audiovisual to start the first video, Dr. Boramani. We are holding biennial world conferences. Every 2 years there is a world conference. And our next conference is jointly with All India Institutes of Medical Sciences in the year 2025. We have started the early bird registration, highly discounted registrations now. You will get the QR code on the screen if you want to register for that conference. Keep the audio also full.
Welcome to International Society of Manual Small Incision Cataract Surgeons. Scleral tunnel incision is a secure incision. There are newer advancements in SICS like 2 mm incision surgery, smart incision surgery. With customization of incisions, the astigmatism can be managed very well. SICS has become a premier surgery now. The International Society of Manual Small Incision Cataract Surgery was launched in 2005 in Mumbai. Dr. Amulya Sahu is the founder chairman of the organization and Dr. Jagannath Boramani is the executive chairman of the organization. The first international conference of ISM SICS was organized in 2005 in Beijing, China. The second international conference was held in Malaysia in 2007. This was a 3 days event with wet lab, live surgeries, and scientific deliberations. This was followed by successful conferences in Indonesia, Sweden, Egypt, Philippines, and South Africa. ISM SICS surgeons were invited to conduct wet lab in Asia Pacific Association of Cataract and Refractive Surgeons Conference in Kuala Lumpur in 2015. Dr. Boramani, as the first editor, published many journals of the organization in the past. The organization started holding World Conference every 2 years. The first Comprehensive Cataract Conference, CCC 2015, was held in Pune. The Aravind Eye Care System organized the second CCC in 2017 in Chennai. This conference witnessed the joining of Help Me See with ISM SICS for simulator-based training. An instruction course as well as wet lab were conducted in AIOC2018 in Barcelona. The ebook, Master's Guideline on SICS, was released during this conference. The organization has arranged multiple programs in partnership with various associations. The World Conference CCC 2019 was a 3 days grand scientific fiesta in Kolkata. The All India Ophthalmological Society started giving ISM SICS 2 big sessions in every annual conference since 2018. ISM SICS has now chapters in almost all states of India and across many countries in the world. We have started training on SICS simulator in partnership with Help Me See. The internet-based global SICS training program was launched during AIOC 2022. ISM-SICS started the publication of journal again in 2022. After the physical launching in Egypt and Bangladesh, during the pandemic, chapters were launched in almost 15 countries. The COVID pandemic witnessed almost 50 webinars with massive attendance. ISM-SICS has got a women's wing to address specific issues of women surgeons. The Emeritus Society of Ophthalmology organized a 2-day hands-on training workshop in Dubai in June 2022. The Australia and New Zealand chapter was launched during the annual conference of the Royal Australia and New Zealand College of Ophthalmologists in October 2022. The 4th CCC was organized by PGIMER, Chandigarh, in November 2022. In February 2023, ISM-SICS conducted workshops and sessions in Emeritus Society of Ophthalmology Conference at Abu Dhabi. The UAE chapter also was launched. In 2023, chapters were launched in Singapore and in Nepal. ISM-SICS was also invited for a study tour in Vietnam. In October 2023, ISM-SICS was given a session and a live surgery in annual Russian Ophthalmic Congress. Dr. Boris Malyagin announced the formation of Russian chapter of ISM-SICS. The 5th CCC was held in Hyderabad, jointly with LV Prasad Eye Institute. In February 2024, ISM-SICS again conducted a workshop, a wet lab and a session in AIOC2024, Abu Dhabi. In the same month, ISM-SICS was invited to conduct 2 wet labs and a session in AIOC2024, Bali. These are the forthcoming events of ISM-SICS.
Thank you very much. Our next World Conference CCC 2025 will be hosted by All India Institute of Medical Sciences in Delhi. We have started the highly discounted registrations now, and you'll get the QR code on the screen. Thank you very much.
Thank you very much, Dr. Borabani, giving up the brief description about ISM-SICS. Now I invite Dr. Nayana Poddar to speak on the topic incisions in SICS. Your time is 6 minutes. Dr. Naina, is it ready? Naina, is it ready? Please, please. Presentation?
Yes, sir. It's showing here.
What happened? It's not coming? Presentation is not coming?
It is
yeah.
here, sir.
Now it is coming. Carry on. Start.
Okay, yes. Good morning, all. Thank you, AIOC and ISM-SICS for this opportunity to speak today on this small but important topic, scleral tunnel incisions. As you all know that the scleral tunnel beginning started by Kretz and Girard in around early 80s, and now we have so many modifications by Samuel Palin, Jack Singer, etc. But Paul Koch was one who described this incisional funnel, wherein it is important that smaller the incision, closer the incision, more astigmatism, smaller the incision, away from the limbus, less is the astigmatism. So this is the concept of incisional funnel. Everybody is aware of the surgical limbus anatomy. We have to remember that a scleral tunnel has 6 aspects: the size, that is the length of the tunnel, the shape of the tunnel, the location, depth, width, and final, the entry into the anterior chamber. So 2 things are important in this incision. One is the initial incision, and the second is the corneal inside valvular incision. This helps us to have a trapdoor effect, and this is very important to maintain the stability of the wound. So this is like a grand entrance. If you have a good tunnel, you have a grand entrance, and the future steps will be uneventful. So this is the concept. So first you have is the external incision, then the scleral tunnel dissection, and the internal. So these are the 3 main stages. So the modifications I'll just name. This is by Jack Singer, the frown one. Then Samuel Palin has this the Chevrolet type of incision. So basic incisions are straight, curvilinear along the limbus, or frown. This is a beautiful animation given by Dr. Boramani sir for construction of tunnel. Here you can see first is the scleral entries, scleral dissection, then the corneal entry, and finally what you have is the opening into the antechamber. This is by the crescent knife. So the action of scleral blade is wriggling or sweeping. Here you can make out, you enter and sweep, come out, enter, sweep. So this is how you do. So you avoid multiple planes. So length depends on the nucleus size and hardness. If it is a cortical soft cataract, you have a smaller incision, around 6 mm, and if it is a hard nucleus which cannot be molded, you have 7 to 8 mm length. The scleral flap should not be very thin or very thick. At every step you have to look at the tunnel blade, it should be visible. If it is deeper dissection, you will enter prematurely, and if it is superficial dissection, you will have a thin, flimsy scleral flap, or you may have a buttonholing. You have to be very careful when you enter. It might lead to Descemet's membrane detachment. Another important concept is you have to create a scleral pocket to hold the nucleus. Then remember, when you do the dissections, take care of the contour. So here you can see this is not the way you should move the blade, but it should be along the entire thickness. Yes, this is a small video which shows you creating a scleral pocket here, and then you extend it. Yes. So most of the times the tunnel is so good that you do not need any suturing. But if at all you feel you are not comfortable, you can go ahead with single vertical stitch or multiple vertical stitches, or you can use a single cross stitch wherein the knot is buried, or a box stitch. So at the end, I would like to say that for creating a tunnel, you need a lot of practice, lot of patience, lot of perseverance, and you can master it. Thank you.
Thank you, Dr. Nayana. We move on to the next speaker, Dr. Aarti Hadap. Any discussions with the speaker and the moderators at the end of the session, we will do that. So, Dr. Aarti Hadap to present on the nucleus management in MSICS. And after that, I will invite Dr. Neeta Dodad to speak on Blumenthal's Minilock technique.
So good morning, everyone. At the outset, I would like to thank Dr. Sahu and Dr. Boramani for this wonderful opportunity. Manual small incision cataract surgery is now practiced in both developed and the developing countries. It involves the extraction of a complete or divided nucleus from the capsular bag through the capsular opening and then through this corneoscleral tunnel. A number of techniques of nucleus delivery have evolved over time. These techniques have their own merits and demerits. So nucleus management involves basically two steps: prolapsing the nucleus into the anterior chamber, and second is nucleus delivery through the scleral tunnel. So after thorough hydrodissection, the nucleus can be prolapsed into the anterior chamber by the various methods like hydroprolapse, viscoprolapse, and prolapse with the Sinsky hook. Hydro procedure should never be done with anterior chamber full of viscoelastics. So the tip of the cannula is placed between the capsule and the cortex, and fluid is injected continuously. The wave of the fluid passes through the nucleus to the opposite side, and one pole of the nucleus pops out. So this technique works best for the soft cataracts. Rest of the nucleus can be prolapsed using tip of the cannula or the Sinsky hook. Another method is by using Sinsky hook, which can be hooked at the equator of the nucleus. The nucleus is then pushed across the opposite side, and one pole is prolapsed out of the bag, and then by upward and the outward rotatory movement, rest of the nucleus is prolapsed out of the bag. I think some of the videos have played early. So once the nucleus is in the anterior chamber, nucleus delivery can be done by various techniques. To simplify, we can discuss them as technique where nucleus is delivered in toto and where it can be done by phacofragmentation. Blumenthal's mini nucleus technique will be discussed by Dr. Neeta, and endoexpression of nucleus will be discussed by Dr. Kodial. And snare, I think, will be covered by Arpit. So they have made my job very easy, and I'll try to discuss some commonly used technique in the following slides. So sandwich technique. Instruments required for sandwich technique includes wire vectis and the Sinsky hook. Firstly, the visco is injected below the nucleus to push the iris and the bag down, and above to protect the nucleus, to protect the endothelium. The curved vectis is then injected underneath the nucleus and Sinsky hook above the nucleus, and the nucleus is extracted with gentle depression of the scleral lip. So this is another technique with irrigating vectis. Irrigating vectis has an anterior end with 3 small irrigating ports. Each port is of 0.3 mm in size. The posterior end is connected to the syringe. Check for the patency of the port. Then, just a second. Yeah. Check for the patency of the port. Then the irrigating vectis is then inserted sideways under the nucleus to engage the nucleus. Then the superior rectus brittle suture is pulled, and the irrigating vectis is slowly withdrawn without irrigating. Once the superior pole of the nucleus is engaged in the scleral, in the tunnel, the irrigation is then started, and vectis is slowly withdrawn while depressing the scleral lip. You can also tighten the superior rectus at this stage if in case you are used to take the superior rectus. So this is another way of using the vectis. After filling the anterior chamber with viscoelastic, vectis is inserted underneath the nucleus. The nucleus is then delivered by gentle depression of the scleral lip with non-dominant hand pulling the superior rectus. So here is another video of the same technique. Now visco-expression is practiced very commonly. Anterior chamber is filled with OVDs, superior rectus brittle suture is tightened. The curved visco cannula is inserted under the nucleus so that the tip of the cannula appears over the iris at around 6 o'clock position. OVD is then injected, and simultaneously the floor of the tunnel is depressed with the cannula itself. Along with OVD, the nucleus just comes out very easily. So we've been talking about managing astigmatism during the SICS. So here comes the role of phacofragmentation. Phacofragmentation or phacosection is the only way by which the tunnel size can be minimized to 2 mm or let's say 4 mm, where the foldable intraocular lens can be implanted. And in experienced surgeon's hand, the results may be comparable to phacoemulsification. So to my take-home points will be, tunnel should be of adequate size, Adequate viscoelastics injected above and below the nucleus is the best thing. Nucleus is properly engaged by the vectors, and slight but adequate depression is given on the scleral lip to ease the delivery of the nucleus. While using the vectors, ensure countertraction is given by pulling on the superior rectus. Thank you so much.
Thank you, Dr. Aarti, giving the good description about how to manage the nucleus. Now I invite Dr. Neeta to speak about the Blumenthal's mini-nuc technique. Next speaker will be Dr. Kimya Chauhan. Please be ready.
So, that's it. So, very good morning to one and all. I take this opportunity to express my gratitude to Dr. Sahu, Dr. Boramani, and AIOS team for this wonderful opportunity. Today, I'll be speaking on Blumenthal mini-nuclear technique. Professor Michael Blumenthal from Israel has given many innovations in the world of ophthalmology. This mini-nuclear technique, which enables the expression of any grade of the nucleus through relatively small scleral tunnel with the help of sheets, lens glide, and anterior chamber maintainer. The steps which essentially differ from normal MSICS surgery here are the sclerocorneal tunnel, where there is a central horizontal straight incision, and at the end we have two radial cuts and forming the deep scleral pockets. The integral part of the mini-nuclear technique is use of anterior chamber maintainer, which gives a stable intraocular pressure and maintains the AC. So that gives the easy execution of all the steps. And second thing is the nucleus delivery, which is assisted from the hydrodynamic pressure of the AC maintainer and the counter pressure with the sheets glide. Extra instruments what we require are MVR blade, fixation of the AC maintainer, and sheets glide. These details will be covered by Dr. Kimya. So this is the short animation video showing the scleral tunnel of a Blumenthal mini-nuclear technique. Initial central straight incision followed by the radial cuts. In this figure we see the extended deep scleral pockets and the nucleus delivery, which is guided with the sheets glide and the hydrodynamic pressure of the AC maintainer. This is the video showing the same technique. We see a central straight scleral incision, two radial cuts at the end of the incision, and forming of the deep scleral pockets on both the sides. These scleral pockets help the engagement of any grade of the nucleus, giving the fish mouth effect and the easy delivery of the nucleus. So formation of the deep scleral pockets on both the sides. Once the nucleus is prolapsed into the anterior chamber, the AC maintainer is on. The pressure of AC maintainer and slight counter pressure with the sheets glide at the posterior lip gives the easy delivery of the nucleus. This is slight a variation of the Blumenthal incision. Instead of a straight incision and the radial cuts, the incision here we see is a totally frown incision. The astigmatic effect of the frown incision and the straight incision with the radial cuts are comparable. So the beauty of this Blumenthal technique is you can modify as per the surgeon's comfort and the surgeon's expertise and this is gives a reproducible results. So again we see a beautiful curved frown incision, and once the nucleus is into the anterior chamber, the process of nucleus delivery is same as it was described in the previous video. Here the nucleus is prolapsed with the help of Simsky hook. AC maintainer is on. And the nucleus delivery is guided with the help of Sics glide. So Sics glide is a small piece of a plastic which is 2 cm long, 4 mm wide, 0.3 mm thick, which is designed by Dr. Sics in 1978, which guides the nucleus out of the sclerocorneal tunnel, gives the direction and the positive pressure at the posterior lip. So there is one more variation. Instead of using the Sics glide, iris spatula or the iris depositor is used to engage the nucleus into the sclerocorneal tunnel. And once it is engaged, it gives the auto delivery with the hydrodynamic pressure from the AC chamber maintainer. So we have seen there are several ways of nucleus delivery in MSICS surgery. In blue menthol mini nuclear technique, essentially the integral part is the AC maintainer, which maintains the AC depth and intraocular pressure for giving easy execution of each step of the surgery. And the visual outcome and surgically induced astigmatism are definitely comparable with other techniques. Because of this easy execution, this is definitely useful for all the beginners with the minimal rate of complications. So thank you for your patient hearing.
Thank you, Dr. Nita, given a brief description about the mini-nuc technique. So now I invite Dr. Kimya Chauhan to speak on AC maintainer, the third surgical hand.
Dr. Kimya is also a trainer with Help Me See, and Help Me See has been a partner of ISM SICS for last 10 years, and they do yeoman work in training youngsters and the not so young in various types of cataract surgeries, earlier only manual SICS, but now also phaco. So over to you, Dr. Kimya.
Okay. At the outset, I'd like to thank ISM SICS and the organizers of AIOC for giving me this opportunity. Let's start. Yeah. So we know we have different techniques of, can you hear me now? Yeah. We have different techniques of dealing with the nucleus in M6 procedures. So let's talk about ACM today. So this basically, antechamber maintainer has a serrated margin and he has a bevel edge. And the cannula is a single port cannula, which is very slender. This comes in different sizes and different patterns are also available of AC maintainer. So first we'll see how to insert the AC maintainer. You have to go with the MVR blade inside and go towards 6 o'clock, pointing towards 6 o'clock. And you have to insert the antechamber maintainer then, and first the bevel should be always up and then you have to make the bevel down. Okay, that is very important. Then second thing is, it shouldn't be very long or short. If it is too short, it can come out easily. If it's too long, it can come in the way of instrumentation. Always check the patency of it, remove any air bubble if it is there, and then start. And the bottle height should be around 50 to 70 centimeters ahead. So we'll see now the role of AC maintainer in all these different steps of cataract surgery, how it helpful. So this, in tunnel construction, you always know that whenever you have to have a tunnel, you have to have positive pressure from within the globe. Like, if it is very soft, it's difficult for us to make the tunnel, right? So you have to have a very good positive pressure. So AC maintainer does the same thing. It gives you adequate counter pressure, so tunnel becomes very easy for the surgeon to make out. Also, the keratometry becomes very easy when you have AC maintainer inside. In Rexis creation, you have actually, it's very quick and easy. Only when the surgeon is novice surgeon, sometimes you have difficulty when there is a flap, it flutters. But that time you can actually hold the flap with the other hand, instrumentation from paracentesis, and make it flat on the lens. So that becomes easier then. And of course, it's not a crime to use viscoelastic, right? When you have ACM, it's okay. To start with, you can use viscoelastic as well. In nucleus delivery, Dr. Neeta actually explained beautifully how to use the Sheets glide. And as she said that, yeah, you can use this also, the iris depositor. At the same time, you can use McPherson forceps also to take out the nucleus. In cortex wash, it is very easy because you have a very slender cannula. You can have very good aspiration at local cortex also. And because the AC is well formed here, because always the ACM is there, and the PC is quite low. So chances of PC rupture are very less. So it's very good for to start with as a novice surgeon. Always the pupil is dilated, and there is less chance of expulsive hemorrhage because there is always positive pressure. So that is also a very important point. In IOL insertion, yeah, to start with, you can have some problems because when you insert the IOL, because the pressure of the ACM, or the water hydrostatic pressure, the lens can start coming out, but you can do it with practice. And you can, as I said, you can use viscoelastic for first few cases, and then you can shift to only ACM. It's a learning curve, but you can definitely do it. Yeah, in case of posterior capsular tear also, because it is positive pressure, there is less disturbance of hyaloid phase. So it prevents the further vitreous loss, and it maintains the AC, reduces fluctuations, and you can directly actually put the IOL inside the sulcus. Whenever there is vitreous loss also, you can go ahead with vitrectomy without any complication further, and you can easily aspirate the cortex with the ACM there. So advantage of ACM is there's a one-way flow, there's a low turbulence, then no post-op IOP spikes, less chance of inflammation of post-operative because we are not using viscoelastic, less chance of TAS, less endotoxin contamination. As is continuous irrigation of medication, you can even go with adrenaline or antibiotics to the AC maintainer, and it also acts as tamponade to prevent the bleeding. In different scenarios, you can use AC maintainers, like if you have to just implant secondary IOLs, descended IOL dialing, of course, washing any cortical matter which is remaining in previous surgery, removing it by foreign bodies. Even sometimes people are doing trap under ACM as well. Injecting air on visco are some variations you can do with ACMs. And basic retinal surgeons, they do procedures on vitrectomy's eyes with ACM maintainer. And there is something called as trocar ACM, which is pioneered by Dr. Amar Agarwal. So it's something like this. The trocar looks like this, everyone knows. So what you do is you go transconjunctival, 0.5 millimeters from the limbus, 45 degrees first, and then you enter perpendicular in the anterior chamber. Okay? And then you can remove the trocar and attach the infusion line. And then you can use it same like AC maintainer. It is very useful in retinal surgeries as well. And these are all different techniques of SICS, but whatever the studies are saying that post-op surgical astigmatism was comparable in all the processes. Not very different in AC maintainers, they are all comparable. And as even of us know that ECC, SIS and FECO, least endothelial count losses in M6 surgeries, SICS surgeries. So as all these are very prominent figures in M6 procedures, every M6 procedure it has own beauty of its own and its perfection. Okay? Thank you so much, and my sincere gratitude for Dr. Boramani and Eli Prasad for the videos. Thank you so much.
Thank you, Dr. Kimaya. So now I invite Dr. Pranava Kodial to speak on Boramani's end expressive nucleus. Next speaker is Dr. Jagdish Reddy.
Good morning, everyone. I thank the AIOC committee for giving me this opportunity. I also thank Dr. Boramani for inventing this wonderful technique and for the videos that he's lent me for this presentation. I'm happy to inform you that this technique got the Best Publication Award in the IJO of 2022. No financial interests. As always, I'd like to begin by remembering Dr. Kuwar Vikram Singh Dhaliwal, a young, wonderful surgeon who demonstrated this technique many times. You can still see his videos on YouTube. Unfortunately, he passed away at a young age, and his tragic loss was felt by many on a personal level, as well as the world of SICS in general. He was the one who coined the term nucleus endo-expression for this technique. So nucleus removal in MSICS involves pulling techniques and pushing techniques. Pushing techniques conventionally involve the use of an AC maintainer, as described wonderfully by Dr. Kimaya, irrigating vectis, and visco expression. But sometimes we are confronted with the Bahubali of cataracts, also called as the grade 4 hard nuclear cataract. At these times, we have to invoke a divine superpower. We have to invoke the Rajnikant of nucleus removal techniques, also called as nucleus endo-expression. Let's watch a video of this technique. Note the exquisitely shaped frown incision and the deep dissection into the sclera, the side pockets, allowing it a snake's mouth effect that allows you to accommodate a nucleus much larger than the size of the incision. Here the incision size is just 5.5 millimeters. So we prolapse the nucleus into the anterior chamber as usual with a Sinski's hook. Then we depress the incision to engage the nucleus within it. We enter through the side port with the Sinski's hook and then gently push the nucleus out. You can also use the Sinski's hook to cartwheel the nucleus out, as shown here. Another demonstration. Here the surgeon has used the additional horsepower of an AC maintainer to push the nucleus out. The incision here is nasal, but you can also use it with any other type of incision. You can also use other instruments like the forceps to hold up the incision or a sheets glide to help the nucleus out. Some people prefer to use viscoelastic instead of an AC maintainer, but it's a matter of personal choice really. See, even in the movie Sholay, when Viru is overwhelmed by Gabbar Singh, he calls on the help of Jai. So similarly, additional other techniques can also be used to lend additional muscle power to endo-expression. Here the nucleus is so large and hard that it gets trapped within the incision and refuses to come out. So we can use the technique of phacofragmentation to bring down to the nucleus to a smaller size. We use the Sinski's hook to chop off a part of the nucleus. Then we push the nucleus back inside, reorient it with its longer axis facing the incision, then engage the nucleus within the incision. And then push it out with a Sinski's hook. So after seeing these surgeries, you must be worried what must be happening to the corneal endothelium and the iris. Is there a lot of trauma to it? But no, because if you notice that all the wrestling that we do with the nucleus is within the incision, so the corneal endothelium and iris are spared the injury. The advantages of this technique are, of course, you can remove a hard nucleus through a small incision without the risk of a nucleus drop. The disadvantages are damage to the corneal endothelium and iris, causing hyphema. But these two are seen with newcomers to this technique. Once you get the hang of it, the incidence goes down. Precautions are always good. You can, especially in cases of shallow AC and hypermetropic eyes, we can use a lot of viscoelastic and avoid iris entrapment during nucleus expression to avoid damage. Thank you for your patient listening.
Thank you, Dr. Pranava. I think I invite next Dr. Jagdish Reddy to speak on the art of capsulorhexis. Our next topic will be on topical MSIS. Dr. Jayasri will speak on that. Yes, ready. Any questions on any topics, please be ready. End of the session, we'll have the discussion.
Before the slides come up, Dr. Kim has told multiple advantages of AC maintainer. There is one more advantage. AC maintainer doesn't allow anything to go inside the eye. So during the surgery, if you want, you can instill the topical anesthetic. It can never enter the eye, but it will have the surface action. That is the advantage of AC maintainer.
Good morning, everyone. At the outset, I would like to thank the AIOS Scientific Committee members and the ISMS-ICS for giving me this opportunity. Very interesting videos all throughout the session. Mine is purely basics, and I'll try to make it more interesting. Let's see, my topic is art of capsulorhexis, no financial disclosures. So to talk about the capsulorhexis, first I would like to tell you, we'd want to have a clear view of the field during the procedure of the capsulorhexis. We should clearly understand the pressures which are involved in the eye. We should be understanding the forces during the procedure of the capsulorhexis. So when I talk about the clear field of view, what I mean is actually aligning the head of the patient to the objective of your microscope and utilizing your red glow to a proper extent. There are other aftermarket things to enhance your red glow, especially the Omni Glow and everything. You can see in the picture the difference actually when you switch on an Omni Glow. This is something which you can also use. You also should be mindful of the stagnation of the fluid. For example, in a peribulbar anesthesia and stuff, you would see there will be a ballooning of the conjunctiva, which you want to take care of it by removing the chemosis. You can either puncture the conjunctiva and then remove the fluid out over there. Here the main criteria is to make your field viewer, if there is any meibomian oil or anything like that over there coming across, clean it up, keep some amount of viscoelastic and take care of it. Now when I'm talking about understanding the pressures, I'm talking about even the visco which you are injecting into the eye. Make sure it's the optimum way of injection. I mean, not more, not less. As you say, when you make a dish, it's the optimum amount of salt. It's the exact amount which is needed. If you make it more, the iris, there's a lot of pressure. The iris will try to come out. When you insert a capsulorhexis, a forceps or anything, a lot of visco will come out. And if you go under, also it would be a problem because you would not be actually having a good clarity, and also you would not have enough pressure to do it. To go back, when I talk about the pressure, the psychological pressure, even I want you to be in a comfortable position. Your hand, for example, if you're making an incision completely a little away from that, you can make an incision, but when you're trying to revolve your rhexis needle, your hand as such, your wrist joint, if it's overstretched or inside like a flexion, you cannot make that circle. Make sure it's in a comfortable position where you can actually make that circle and the axis is actually aligned to the incision place. So when there is a lot of pressure, you try to depress the incision, and also a lot of visco will try to come out. Additional things which you can aid for, it's actually, if the pupil is smaller, you probably want to use like a BX ring or iris hooks to increase the field of view. You can also use enhancing devices. If it's a mature cataract, you could use something like a trypan blue. For example, when you see in this video, I just want you to notice once it's a mature cataract, you're probably using over here a trypan blue under the guide of air, and then making sure you put good amount of visco from the other end so that it actually clears off the anterior chamber, no ripples or anything over there. Preferably, these are the instruments which I use. There are a lot more instruments. When I'm talking about the instruments, the top one you see is a cystitome critically, and it has two bends. The first bend is usually I make it not completely vertical nor acute, a little obtuse, probably around 110 degrees and so. And the second bend is basically dependent of how the surgeon holds it. It can be a little obtuse, anywhere between 100 to 120. It depends on how the surgeon holds the capsulorhexis needle when he's doing. The other thing is the capsulorhexis forceps. This is, you can also use microcapsulorhexis forceps. These are the two things which I usually use, and so that's what I'm showing it over here. A typical mature cataract. I want you to observe over here when I'm making the incision, and then I'm trying to take it to the periphery to increase it dimension, and then see I have a difficulty in getting it back, so I'm applying a force towards inside. I would like to discuss about these 3 points in the next slide. These are the points of relevance. The topmost slide when I've actually used it. So you have to remember the capsule as such has some inbuilt potential energy inside it. As soon as you make the nick, the potential energy is lost. But now there are a lot of extrinsic factors which actually involve in this. the fluid. For example, if it's a hypermature cataract, there's a fluid which is coming out which will create a lot of radial force, a centrifugal force to actually cause the radial tear. The zonular complex can also cause a peripheral tear. So these extrinsic factors should be negated by the surgeon's extrinsic factors to get a perfect rhexis over there. So in the second picture, the force which you're using is more like a stretching force. You're trying to go along the border of along the circle of the iris and then making it. In the third one, when I was not able to I was trying to use the shearing force to actually move it inside. It is more like a centripetal force. Do observe, I had a difficulty because I was using a capsulorhexis needle, but if I was using a capsulorhexis forceps, probably I could have done it with more easily because I could even use the 90 degrees, the tangential force to pull it. So the tangential force actually helps us out because in a cystitome, you're again using the same radius along the zonulars, so it might not be so good. So in practice, I would still prefer a combination of these two instruments. Coming to a capsulorhexis forceps, it's a routine thing. You go depth, make a small depth, and then cut the nucleus, and then you make the complete capsulorhexis. Here, when you observe that, you have actually seen that you don't need much of a places to grab the rhexis as such, because it is easier to do it. So I'm talking about visco and hypermature cataract. You just make sure that when you're using a hypermature cataract, a lot of people use cohesive OVDs, and you have to make sure when you use a lot of cohesive OVDs, you're trying to push the whole the lenticular complex downwards. Indirectly, the pressure, the vitreous also injects pressure, so all these come up, the fluid comes up, and it is actually bad to give the cohesive OVD. There is a spiral rhexis over here, which you can use in a hypermature cataract, which I wanted to show. You can use a combination of devices that will take care of it. There you see, again, visco again. In the third one, there's a double rhexis. Here you created a small rhexis, and then you're extending the rhexis. So thank you, everyone.
For those wonderful tips on capsular rhexis, which is perhaps the most crucial step in getting a very good outcome in cataract surgery. Now I would request Dr. Jayashree Barua, who is from the eastern part of the country, from Jorhat, Assam, to speak on topical SICS tips and tricks. Today's ophthalmologist, when we have become refractive surgeons, and our patients not only expect good outcome, but they expect a completely painless surgery, and they are not even willing to take that small injection which we would give earlier. So this is what gave phaco a huge advantage over other types of cataract surgery, even the femto phaco. But I think with SICS also, Dr. Jayashree will be telling us how.
Yeah, thank you so much, Dr. Parikshit, and welcome one and all. Good morning. So I'll be basically discussing on not how we are doing the surgery, but the basic tips and the tricks which we can follow to convert from peribulbar injections to topical anesthesia. Now, why are we talking about topical M6? Now, we have been operating upon our phaco patients, and we send them off without giving the patch nowadays. So even our SICS patients, they deserve this benefit. We need to see the smiling faces in all our patients, not only in our phaco cases. So it's the ultimate form of low-risk anesthesia. You have a non-invasive technique, but I say that it's ultimately a personal choice, and it is the surgeon who is to decide whether you are confident enough to shift from peribulbar to your topical anesthesia. Now, is topical anesthesia safe in M6? Now, most of us I know are doing topical M6, so it's for the beginners. So what are the things that come to our mind? Is M6 possible under topical? Can it be done in all the cases? And do we need to modify some of our steps while doing this surgery? Now, as Dr. Gogte has already mentioned, we need to come out, do we actually need to come out of our comfort zone which we are having with the peribulbar? You have echinacea, you have a wonderful anesthesia, so do we need to come out of it? See, every technique there should be a scope for improvement, and anesthesia, it's also the same. Now, it took me just a personal experience, it took me 40,000 plus peribulbar SICS cases to ultimately decide to shift to a topical M6. But it took me just 38 FICO cases to shift into topical. Now, why was this? So I sat down and I analyzed my records. So I was completing my SICS cases in 3 minutes, and I was doing it under peribulbar. I was completing my FICO case in 10 minutes, and I was doing it under topical. So what was the difference in my mode of operation? So why didn't I shift earlier? Was I worried that the patient will experience some discomfort? I was still using the superior rectus bridle suture, which I have left now. Will the heart nucleus management be difficult, and what if I get a complication? What if I land up in a PCR? Or was I just searching for an excuse maybe for avoiding peribulbar and shifting to topical? So before understanding, before trying to jump into any conclusion, I decided to just analyze that where actually we are working upon. So we have our sensory terminations of the 5th cranial nerves that are concentrated in the cornea and the ciliary body. And these are the areas where our topical anesthetics are working, and these nerves, they are blocked by a minimal concentration of the drug. So definitely we have the advantages. You don't have the complications of peribulbar injections, you have a lower intraocular pressure, and you have the return of sensitivity soon after the surgery. But initially, yes, there are limitations. You have to choose cooperative patients. You have to choose the easier cases in the beginning. Avoid doing it when you anticipate a long surgery or when you know that it's a complicated case. So for me, it's always the proparacaine drops. I have never used the lignocaine jelly, but yes, they do help us at times, and most of us prefer to use it. And intracameral lignocaine nowadays, they work wonderfully. We have intracameral injections that work with your dilatation, that helps you with your anesthesia. So the technique is the very simplest of all. So you have a preservative-free anesthetic agent. You ask the patient to look up, instill a drop into the fornix, ask the patient to close his eyes, and your job is done. But try to avoid the cornea to avoid the epithelial toxicity, and try giving the drops on both the eyes just as to eliminate the squeeze response of the patient. It's going to help you a lot. So we have basically 3 ingredients for a successful topical MSICS. You have to prepare your patient, you need a careful patient selection, and you need your own preparation as well. So coming to the first point, the patient preparation, adequate preoperative counseling is very important. You have to remember that the microscope light is very bright initially for the patient, so start with a dim illumination. Then once the patient is adjusted, you can slowly increase your illumination. You have to remember that the patient has this intact eyelid sensation, so don't fiddle too much with the speculum. And then thirdly, it's very important that the patient can obey your command and control his movements according to how you want. And it's normal to feel some pressure sensations inside the eyes, and the patient should be aware of this. So next, coming to the patient selection, you have again 4 suggestions to pick the winners. There should not be any communication problem between you and your patient. The patient should be able to follow your command, follow your what advice you're giving him. Choose the easier cases initially. And when you're seeing some patients in the OPD, when you're doing your AT or other procedures, you come to know whether the patient will cooperate in topical M6 or not. So avoid fuzzy patients. So it's basically the preoperative counseling and a careful patient selection that maximize your chances of success and minimize the stress factor both of the patient as well as the surgeon. We also as surgeons, we need our own preparation. We have to understand the eye movement control. We have to understand there is the intact sensation of your periocular tissues and the sensitivity of the iris to surgical trauma. Initially, saccadic movements can be disconcerting, but more forceful movement can create a problem for you. Can I take a minute?
Yes, of course.
You have to be aware that the patient will be sensitive to traction on your speculum or the stimulation of your eyelids. When you're taking out the nucleus, at this point, maybe initially you can go for the intracameral injection because stretching can be painful for the patient. So it's up to you to decide whether you are apt enough to shift from peribulbar to topical. it is the patient who is going to decide like how he is going to cooperate while you are performing the surgery. It will definitely depend upon your skill and experience and the type of cataract you are dealing with. So these are the immediate post-operative pictures, and you can see the smiling faces in this too. And why I picked up these two patients, because both of them were they had a little psychological problem, but this was the case where I opted not to go for phacoemulsification because I was worried that they may just, they can get up from the bed, so how will I manage such a case? So it was basically a combination of topical and your vocal anesthesia, how you talk to the patient while you are performing the surgery. So I hope this presentation was useful to improve your confidence, to maximize the chances of success, and enjoy your experience of M6 surgery. Thank you so much.
Doctor, one just question. Would you be doing a topical anesthesia on all your SICS patients, or you would really select them?
The selection criteria I have dropped down to maybe one person. Like the patient, I had a patient recently who was operated, and all my colleagues and my assistants, they know that I do all the cases in topical anesthesia. But since she was mentally retarded, she didn't allow even other investigations to be done. At that moment, I was worried that whether I should go for peribulbar or I should go for topical. And it was on table. After taking the consent from all my assistants, they all told me, ma'am, injection dal dijiye. Don't do it under topical. But somehow my crux was telling me, that no, if I push the injection, she'll run away from my OT. And so I just calmed her down, and it was done totally under topical anesthesia, no xylocaine jelly. It was done only on drops. So it's how you deal with the patient that is more important, and definitely your confidence. I will not ask a novice surgeon to just start doing topical from day one.
How about augmenting it by a subtenon or an intracameral anesthesia?
I go for intracameral. When needed, I go for intracameral, not subtenons.
I think we'll have discussion at the end. So please call the next speaker, Dr. Arpit Shah. He is going to talk on snare the cataract. I think by mistake in program it is printed, snare the 6 minutes, but don't snare your 6 minutes.
Yeah. Yeah. And since Dr. Nitin Verma is yet to come, we will have some time for discussion. So please have your questions ready.
Good morning, everyone. At the outset, I would like to thank Dr. Boramani sir, Dr. Sahu sir, ISM, SICS, and AIOS for giving me this opportunity. So I'll be talking about snare technique. So importance of this technique is incision size is close to phacoincision, which is slightly larger than that, but 3.4 mm incision is there. Parts of the snare, it has 2 needles used. First needle is acts as a body. Second needle is handle, which are the 18 gauge steel needles. It has 2 tips in the front, which is a very important part of it, and it has a 36 gauge steel wire. So unique about Dr. Anil Shah's snare is it has 2 holes at the tip of the needle. Is a magical concept that allows rotation of the loop inside the anterior chamber when the handle rotated externally without collapsing AC or displacing the nucleus. Loop size can be adjusted to engage the nucleus according to its size by pushing and pulling the handle of the snare without damaging intraocular structures. Sharp inner cutting wire divides hardest nucleus easily. Any grade of cataract can be managed using this snare. Smooth movement of the loop as very thin wire passes through a very big lumen. Few points to be remembered when you are new and when you are using the snare is appropriate size tunnel. That is external lip should be 3.5 to 4 mm. So don't extend it initially only. If you require that snare technique is not working in your hand in initial stages, then you later on extend and then do it your routine technique. But initially when doing snare, trying snare, go for 3.5 to 4 mm incision. Free floating nucleus in AC is must. Cohesive viscoelastic substance like sodium hyaluronate all around the immobile nucleus. Coat wire loop with the visco to protect endothelium. When entering tunnel, loop size can be made smaller by pulling the handle. Once the tunnel is crossed, the loop size can be adjusted to the size of nucleus by pushing and pulling the handle. Anterior posterior size of the cataract is around 3.5 to 4 mm approximately. Large loop can damage the tunnel, corneal endothelium, iris and PC. Small loops fail to engage the nucleus. Snare loop size should be adequate to engage the nucleus. So bisection or trisection can be done depending on the size of the nucleus. Hard nuclear fragments removed by McPherson forceps, 11 long APA McPherson forceps. This is the number. There is no financial interest, but we are, Dr. Anil Shah is using this, and even I am using this since long time. This gives better grip to the nucleus for removing it. Soft nucleus fragments can be removed by 2 Vectis. We are coming out with a small modification in the snare. So contraindication for the snare: if eyeball is hard or no hypotony, if nucleus is not free floating in the AC, if anterior chamber is not filled with viscous, if AC is filled with saline or BSS, don't attempt snare using snare. If ocular movements are present, never use snare with when AC is filled with BSS or RL. That is one important point.
Dear colleagues, this is my method of doing manual small incision cataract surgery with snare. I preferably use transconjunctival limbal tunnel incision. Usually the incision size is 3.5 mm to 4 mm. After prolapsing the nucleus into the anterior chamber, use adequate visco so as to immobilize the nucleus. I preferably use sodium hyaluronidase so it makes the nucleus stable in the anterior chamber. When you are using snare, make the loop smaller than the size of the incision. As you cross the tunnel, increase the size of the loop according to the size of the nucleus. The trick behind snare technique is engaging the nucleus. If you do this properly, then you can master this technique very easily. Always pass the loop obliquely in the angle. One arm of the loop goes above and one arm of the loop goes below. And after engaging the nucleus, pull the handle so as to divide the nucleus into two halves. You can do bisection and trisection with snare, and any grade of cataract can be removed easily through 3.5 mm incision. This is white intumescent cataract in which the bisection is done with the snare. The main advantage of snare is that when the bisection is done, the loop becomes smaller. So it is away from the endothelium, it is away from the posterior capsule and also from the iris, and it doesn't cause any damage to the tunnel. So that way it is least traumatic in the anterior chamber. Now this is a hard cataract, grade 3. Here I will show you how the trisection is performed. One arm goes below and one arm goes above, and engage the nucleus and divide it into one piece. Now the nucleus is rotated, and again another snare is used to engage the nucleus, and a division is completed. So here the trisection is done, and these nucleus are easily removed by McPherson forceps. I prefer McPherson forceps over Vectis. It doesn't cause any damage to the endothelium. Snare should not be used in hard when the eyeball is hard, when the eye is moving, and when there is a high intraocular pressure.
Thank you so much. Thank you.
Thank you, Dr. Arpit, giving us the beautiful picture of the snares. So I think very simpler in the hands of the, masters. But in the beginning, probably we may land in complications. But however, one has to learn the technique. It's a very important technique because we are in India, we get a lot of hard nuclear cataracts. If you can break the nucleus in 2 or 3 pieces, it will become easier to take it out in the 3 to 4 millimeter section. So now we are expecting one more speaker to join with us. Before that, we want to have a discussion. But before that, I request my co-chairpersons and moderators to speak a few minutes on any of the topics I would like to. So I invite first Dr. Parikit Gogate to give 1 minute, let us start for the incisions in SICS.
Yeah,
Why
just
don't you-
1 minute for
Yes,
interest.
sir. Yeah.
Audio visual, please. Hello. Please project the image on the screen. Yeah, please. Parikshit,
Yeah.
please proceed.
Incisions in MSHC, any comments you have?
I think the speakers, Dr. Naina, showed the various incisions. Professor Naina showed them very well. And I think incision and CCC are the two crucial steps in doing manual SICS. If these two steps are mastered, then rest everything is okay, fantastic. And in fact, if you look at it, it is just for these two steps that people buy machines worth 4 crores who will just do these two steps, because rest everything, of course, that machine cannot do. Humans only have to do it. So I think if we spend some time on it, on a simulator, on our wet labs, and on our patients, we can save our patients and also ourselves a lot of money.
So may I now invite, any? Okay. So Usha Madam, Dr. Usha Johari to speak on nucleus management MSICS. Any comments?
Yeah. So I think all the speakers were excellent, and the nucleus management that was shown, the different techniques of nucleus management that was shown was too good. And as here the chairperson rightly mentioned, that if the nucleus is hard, it could be cut into multiple pieces. So it is as good as doing a phaco with a low-cost technology, and with the volume in our country, I think we all should master all the techniques which has been very well, covered up today. Thank you, sir.
May I invite Dr. Purendra Vasin to speak on AC maintainer?
AC maintainer.
Please take the mic, please. Any hand mic, please?
AC maintainer, I feel, is one of the most important tool, and we all should use it. And in all cases also it can be used, but especially in cases which are subluxated or in cases which are hard, then we can use it, and it protects the endothelium also, and it makes the nucleus delivery also very fast. And it has been very nicely depicted and demonstrated by the presenter here. I really appreciate this technique. Thank you.
Thank you. I invite Dr. Jagannath Boramani to speak on Boramani and expression nucleus. So you speak on your own technique.
Okay. Endo expression has been nicely depicted by Dr. Pranav Kodial. Generally, we are depending upon some pulling technique or pushing technique. But if you are trying to take out the nucleus, maybe through Vecti, sheets glide or anything, I am doing endo expression with the AC maintainer, because there is always positive pressure in the antechamber. But you can do it with visco also. Many times if the nucleus gets stuck, just push the visco through the side port. That also sometimes presses out the nucleus. Or best way is to take the Sinsky hook in your hand, put it to the side port and push the nucleus out. The pressure is borne by the walls of the scleral tunnel and not by the endothelium. That is the advantage of the technique. We always call it as a hard nucleus, hard nucleus, hard nucleus. But hardness is, it is hard for ultrasound energy. Cataract is not a diamond, so that it is not, with any metal you can cut any type of cataract. For phaco it is difficult to cut a hard cataract, but for SICS, Sinsky hook also can push any hard grade of nucleus. If the nucleus is not able to come out totally, it fragments the nucleus in the scleral tunnel, then you can take out the pieces. And if the size is adequate, it pushes out the surgical nucleus totally. Can I have one or more two comments on the talks?
Yeah. Dr. Deepak?
Okay.
Yeah, please. Yeah.
Can I make one?
Dr. Philip, yeah.
Yes, Dr. Korean, please.
Kuruvilla.
Kuruvilla, sir.
Philip Kuruvilla.
Philip, yeah.
Just a few comments about nucleus expression. I've been using a sandwich technique for this. What I do is with a 2 cc Rexus needle in front of the nucleus and a Vectis behind, and then hook it out. And it's a very good technique if it is mastered, because it is particularly useful for subluxated lenses, whereas the other techniques may have problems. This is very good. The other comment, I want to appreciate the excellent videos and the talks. And about Rexus, the problem is as we enter, the anterior chamber pressure may fall down. So what I do is, again, I use a Rexus needle attached to a 2 cc syringe with visco. And as I enter, I constantly inject visco so that the anterior chamber pressures remain high, and we can easily do a Rexus. The third comment about this excellent talk on topical anesthesia. See, the problem is that when we drape the patient, when we put in the speculum, when we put in the drape, if it is uncomfortable, you will lose the cooperation of the patient. So what is suggested is, what I have found is that if you put a lot of xylocaine on the lid margin also, when you put insert the speculum, it is comfortable, and the rest of it, the patient is.
Thank you, Dr.
will
Kuruvilla.
cooperate.
So may I request Dr.
Thank you,
Deepak to
sir.
give a comment on, again, capsular axis?
Yes.
Capsule axis? Yeah.
Yeah. Dr.
One point,
Deepak.
sir. In endo expression, I would prefer a more blunt instrument like a ball dialer to push instead of Sinsky's hook. If anything happens wrong, then a Sinsky may injure, but a ball dialer like instrument won't injure.
Yes, you can do with ball dialer also. Only advantage of Sinsky hook is that if the nucleus is a big size and not able to come, then the Sinsky hook pierces the nucleus and fragments it. That is the only advantage of Sinsky hook. But I have done endo expression with iris repositor also. Like instead of sheets gliding, I am using repositor in the tunnel to take out the nucleus. If it gets stuck, instead of changing the instruments, I push the same repositor through the side port and push out the nucleus. That is it is possible with any metal instruments. Yes, Dr. Gopal Arora, please.
Yeah. About the topical, I would like to just comment. I mean, there are only two areas where you would avoid doing a topical if you compare it to the phaco. One is holding the eye, if you can avoid holding the eye in SICS. And second, I mean, tackling with the iris, because that is where the pain comes from the patient. So if these two things are being tackled, I'll answer to Dr. Parikshit's question, which all cases you would go for topical. I think any phaco cases can be done with a topical anesthesia in a topical SICS.
Yeah, basically, the painful part is stretch on the zonules. The ciliary body is generally painful. If you stretch the zonules during the surgery, then the pain is there. Otherwise, iris and this thing is not pain. Dr. Amargowal used to do without any anesthetic. He used to touch iris purposefully multiple times and showed that it is painless. So topical only, the surgeon's mind should be confident. It is in surgeon's mind the fear is there. Second advantage in SICS about topical is that we always have peritomy as well as the tenon capsule is cut. So whenever the need arises, you can just push subtenon anesthetic with a blood cannula. For patient, it remains an injectionless because already our conjunctiva and tenon is open, isn't it? Thirdly, psychological what happens, patients are already scared of some sharp needle around the eye. They are very scared of the injection around the eye. But if we say you are doing without injection, again they are scared because without injection I may get some pain, isn't it? So to boost their confidence, what I do generally, I do immersion biometry. So after immersion biometry, I ask the patient, did you get any pain? No, because this thing was touching your eye and I had put only one drop. So I am putting the same drop for surgery, but you will not have any pain. Then the patient feels very much confident. And thirdly, just to boost the confidence of everyone, I have done complicated cases in live surgery where patient was not understanding not my language. Like for example, in Malaysia, I had a PC tear, but still the case was conducted, vitrectomy was done, lens was placed in the ciliary sulcus under topical anesthesia. So everything is possible.
Dr.
This
Deepak,
happened in Hubli also again.
Dr.
once.
Deepak, would you like to give some comments? Just a bit short comments.
Yes. Sir, I have one
Please.
regarding the topical.
Final comment.
Ideally, it should be
our
a
time,
topical
yeah.
or subtenon. Is it a topical? Is it because in we are phaco, we are doing a clear corneal. Maximum time we are doing clear corneal, so there is a no such conjunctival test. Or even in SICS also, I am generally doing a side port. So in the cornea, so there is a no such task. But there is some point. Hello.
No, sir.
There is some point. Is
11.
it, should we tell is a subtenon?
Dr. Jain, be brief. We are going to the next session. We'll start shortly.
topical.
Go ahead. Yeah, please.
Actually, just as I had mentioned, it is the very low concentration of the photograph and
Yeah.
on your ciliary body and the sulcus area mainly. And we have 43 such nerve bundles which are there in the limbal area. So if we have the maximum bundle in the limbal area, that's where we are constructing the tunnel. So that area is going to be relatively painless. As sir has told, everything is in the mind. Because as I have mentioned, it was 40,000 plus SICS under peribulbar, and it was my 30th case after doing phaco. So ultimately it's in the mind. Yes, I'm trying to convince many surgeons to do it. They are able to do, but they are still reluctant. So I'll not, as I have mentioned, I'll not suggest to a beginner.
Please.
Sir, it is
We
painless.
can have a discussion
It is painless.
later.
It is painless. Now the thing is, over counseling also causes little apprehension on the patient. So we should not over counsel them, as my experience is. The second point what I am to highlight about topical, when should you switch over to topical? If in case of peribulbar in block failure, you can complete your surgery without losing your cool, without blaming or accusing your assistant and the patient, then you are in the right stage to switch over to topical. So by this way you can know that now it is my time to switch over to topical SICs, and it is painless. Some apprehensive patients will always be there, so you have to deal it in a different manner. That's it.
So now to just conclude, sir.
Thank you all the speakers and the chairperson for the wonderful talks. And as we all here, we also convinced that SICS not only the need of today, it was yesterday, and it will be in the future tomorrow too. So I invite not only for the India, for every places, because human eye is having same type of cataract everyone. I invite all of them to have a